Hello and welcome to the National Foster Care Month webinar, Creating Partnerships in Kinship Treatment Foster Care. I will quickly go over a few housekeeping items. This webinar is being recorded. This webinar will be interactive, featuring polling questions and a video. The slide deck will be sent out a few days after the event has occurred. Please feel free to use the chat to pose questions and share thoughts and comments throughout the webinar. We will address your questions during a Q&A session towards the end of the event. If we are unable to address all questions during the event, we will answer the remaining questions in follow-up communication. There will be an evaluation survey available at the end, so please take a few moments then to provide us with your feedback. I will now turn it over to Jennifer Marcelli to begin.
Thank you so much, Chris, and thank you all for joining us today. Good morning or good afternoon, depending on where you are in the country today. We appreciate you all joining today for our wonderful event to celebrate National Foster Care Month. So first, I want to welcome you on behalf of the Children's Bureau and the Capacity Building Center for States. I'm Jennifer Marcelli. I'm the Senior National Authorities and Peer Services Manager for the center. We have a great event planned for you today. In a moment, we're going to just quickly do a poll, and then you're going to hear from a young adult and a family consultant with the center on their experiences and the impact of kinship care. And then you're going to hear from the African American Families and Kinship Care Lab, and then the Family Focused Treatment Association. And as Chris said, we'll have an opportunity for Q&A at the end. So please go ahead and post questions in the chat as you have them throughout the presentations. So with that, I think we're going to move to a poll. We just really wanted to see who is in the virtual room today. It's always helpful to know who our audience is. So our questions are: you kinship caregiver, caseworkers, supervisors, administrators? So take a moment and do the poll for us. So it looks like we have a lot of administrators, caseworkers, supervisors. We have some awesome kinship caregivers. Welcome and thank you for coming. All right. We'll wait a couple more moments for folks to fill out the poll.
And we have about 200 answers right now, Jennifer, if you want me to give it another 15 seconds.
Yeah, that sounds great. Thank you. Almost everybody's filling it out. And while we're finishing up the poll, we are going to shift gears to hear from our lived experience experts. And I'm going to do some quick introductions of these folks. So first, we're going to hear from Lenita Berry. She grew up having a passion for her peers and doing what is best for them. She got her started doing advocacy work in 2015 with an organization called Say So of North Carolina. During her advocacy career, she has worked on all three levels of government while also being able to volunteer each year and study business administration and finance at UNC Charlotte. In May of 2022, just not that long ago, she graduated with her degree. So congratulations, Lenita. Locally, she was a youth leader and would advocate for things that her peers wanted and needed. She participated in statewide and national policy transformation when she was a board member at Say So. She made sure that her peers' voices would be heard, especially when influential government leaders were listening. At the beginning of 2018, Lenita started her official role as a child mother welfare consultant alongside some notable nonprofit organizations. And then we're going to hear from Antisha Chesterton, who was raised by her grandparents in a loving kinship placement. When she was a teenager, she was placed for a second time in foster care and aged out on her 18th birthday. As an adult, Antisha has tirelessly worked toward improved quality of care for foster youth. She assisted in the creation of the Dreamer Grant, which was implemented to assist in the prevention of teen pregnancy within the foster youth community and with pregnant and parenting youth. Living what she believes, Antisha became a kinship placement for her sister's 4 children, in addition to her own 3 children. She raised 7 children for a year and a half until reunification took place. She's extremely passionate about engaging in the national dialogue on kinship care and is Nevada's Grand Advocate for Generations United and has completed a certificate in Grand Families Leadership. So we're very lucky to have you both here today. Thank you. And with that, I'm going to turn it over to Lenita.
Thank you so much. Good afternoon, everyone. Thank you all for attending and participating in this event today. And Tisha and I are here to welcome you and kick us off. But before we continue, I wanted to talk about my personal experience with kinship care and its importance. Before I officially went into foster care, I was in a kinship care placement with my older sister back in 2013. She took me in because I was in an abusive and neglectful situation and was pregnant, and she wanted me in a safe place. While living with my sister, we contacted the Mecklenburg County Department of Social Services, and we got resources and help. Eventually, an investigative social worker came to our home to assess our family environment. And while the worker was present, we had a discussion about our current needs and concerns. At the time, the biggest concern was my health and the need for a doctor. Since I was so young and pregnant, many local doctors' offices and OBGYNs would not accept me and admit me as a patient, so I did not receive medical attention while I was pregnant during my first trimester. Having adequate health care was not only the top priority of my family, but it became the priority of the worker as well. After the initial meeting with the social worker, she went over potential options, but every choice was based off the stipulation that I would go into foster care instead of remaining in kinship care. Ultimately, the decision was made to place me in therapeutic foster care where I would get the care that I needed. Although I did not spend a long time in kinship care, I still recognize the impacts of my placement. I believe if I've never been placed in kinship care, I would have a non-existing relationship with my biological family and feel estranged from them. I would also have had a rough time maintaining my family's cultural values while I entered into care. Having family values and relationship is so integral to youth, not only while they're in foster care, but eventually when they either age out or exit care. I share my story not to dampen the incredible work that the investigative social workers do, but to highlight the need for preventative and proactive methods. I acknowledge that some people need foster care, but everyone needs family. People need more than a professional diagnosis, but raw, unconditional support and love. Sometimes foster care or other child removal situations can be limiting because some regulations and practices might hinder workers from going above and beyond for youth. The beauty of kinship care is the family connection and the willingness to do whatever it takes to raise family members. I would also like to acknowledge that I wish more resources that are available to foster parents could be utilized by kinship parents. The lack of resources puts biological families in a difficult position because members want to help, but might not have the tools to take care of youth. So many times I have heard my older siblings and family members wanting to get me out of foster care, but not having the ability to give care. The reality is heartbreaking, but I feel can be avoidable. Thank you all for listening to my story. Now I will turn it over to Antisha for a few words.
Thank you so much, Lenita. Lenita is amazing, but my name is Antisha Chesterton. I am with the Center for Capacity and Building States. When kinship care is something that is near and dear to my heart because when I was 9 years old, me and my 3 siblings ended up in a kinship placement with our maternal grandparents. It was an informal situation, so they received guardianship of us. Unfortunately, due to the lack of resources, that placement was a failed placement, and I ended up in the foster care system at 16. I remained in the foster care system until I aged out. And then I got into a lot of different advocacy work. But one thing that I wasn't expecting to happen, but I was there to accept it, was when my sister's 4 children went into foster care, and I became a foster care placement for her 4 children, as well as having 3 children of my own. So at the time, they were all 7 and under, 7, 6, 5, 4, 2 3-year-olds, and a 1-year-old. Did that for about a year and a half. And then they were successfully reunified with their dad out in Alaska. One of the hardest things about being a kinship caregiver is having that relationship with the family member, with the bio parent, but also wanting to do what's best for the kids. And that was one thing that I struggled with the most, was wanting my sister to do what was best to get her children back, so I can go back to being just the auntie that babysits them on the weekends or just has that relationship with them. And seeing her go in that downward spiral was really hard for me. Even hard to just, set boundaries or know that she didn't have a place to go, or she was homeless, and I had to put the kids as a priority first. When they were reunified, I was extremely happy that they were able to be reunified, because I think that kids should ultimately be with their families. We look at the situation as this is an unsafe situation and we need to keep that child safe, but it should never, unless it absolutely has to be, a permanent thing, right? Children should be able to be reunified, and I think that's the main goal for kinship caregivers. I now work for the Navigator program in Nevada, foster kinship, and I try to give my families back that voice. I try to empathize with them and understand how difficult it might be to see your loved one struggle, while also wanting to make sure that you are doing what's best for your family as a whole, without having to choose one or the other. I think we have to all work as community in order to strengthen families and build them up, so that way successful reunification can happen, and that family member that took on the children are able to still have a good and healthy relationship with their loved one, with the bio parent. And so with my experience with kinship care, I just do my best to try to empower my families to speak up for themselves, advocate for themselves, and get the resources and the help that they need. Because like Lenita mentioned, our formal foster families are able to receive a lot more resources and help than kinship families. And I think that there needs to be some type of balance there. I think that kinship families should be number one, the first priority in placement, but also that they should be able to receive those resources to help them to remain stable, to preserve that placement. Because I think that was a big outcome into why, or reason why I ended up in the foster care system, was there wasn't a lot of resources for my grandparents. And so it was hard for them, to want to keep us, but not be able to because of financial help, mental help, all types of stuff, right? So thank you so much for listening to my story. I think today's conference is amazing, and thank you for being willing to help kinship families and just strengthen those relationships. So I'm going to hand it back to Jennifer so we can get started.
Thank you so much, Lenita, Anna, and Tisha. I hope you see all the love in the chat. We appreciate you guys coming on and telling your story and the why behind we do this work. And I think it's a great way to set up the rest of today's webinar, where you're going to hear more about how we can support kinship. So thank you, the two of you, so very much. On the next slide, we just wanted to have a slide. Please visit the National Foster Care Month website on the Information Gateway. They have a lot of amazing resources on their website. So if you haven't visited that, please do. And with that, we're going to turn to our first presenters. We are going to hear from Lisa and Joe from the African American Families and Kinship Care Lab. I'm going to introduce them. So Joe Strong, PhD, is a postdoctoral research fellow in the African American Families and Kinship Care Lab at the University of North Carolina, Greensboro. He is a gerontological social worker with a background in biological sciences who's interested in social factors that affect mental and physical health in older adults, with a particular emphasis on dementia and other neurodegenerative conditions. And then we have Lisa Taylor, who works for Family Solutions, providing outpatient mental health services to each of her clients by using a comprehensive approach with a wide range of interventions. Lisa believes enhanced therapy can alter the effects in which families have experienced complex trauma and provide a better outcome when clients receive the proper tools necessary to focus on healing and building resiliency within the family unit. She's one of the research assistants on the Kinship Care pilot study in the Department of Social Work at the University of North Carolina, Greensboro. The family's impact on the development of African American children in kinship care. Her role includes community outreach, locating sites in the community to collect data from grandparents and recruiting grandparents to participate in the study. Lisa's passion for this work is derived from her informal placement into kinship care. So we're very lucky to have you two here. We're excited to hear from you, and I think I'm turning it over to Joe first.
I'm sorry, this is Lisa, I'm sorry to say.
Hello, hello, hello. Yes, it is I, Lisa. Thank you so very much, Jennifer, for that warm welcome. And again, thank you everybody for being with us on today. And we come to you and we are here to do what we can to make sure that we make it more clear what we are actually doing at UNCG. Who are we? Who are we? Well, Dr. Washington and the research team you see pictured right here, we are the ones that connect directly with Guilford County, Rockingham County's different social service agencies, even outside as far as Wake and other areas. We had to stretch it further. We were just in this general area here at Guilford County, but we ended up stretching out when the pandemic hit because we could not see those that we were seeking out, that we were trying to recruit. We could not see them face to face. So we needed to make sure we were gathering as many participants as we could. So we stretched out a little bit further. So again, we connected and got participants from kinship care groups as well, along with churches. We would go to churches and speak. We would go to different community events, wherever we would go in order to try to recruit those to be a part of the study. And actually, I can just kind of put a little blurb in here to say that I met Dr. Washington, of course, as Jennifer just got finished reading, at Family Solutions, because I was doing a kinship care group there. And how that actually took place was the fact that there were clients that the therapists were seeing, and a lot of those clients were in kinship care with their guardians, with their kinship caregivers. And those kinship caregivers needed assistance. They needed help. They continuously asked for finances. They continually asked, is anything out there to help me? I cannot do this by myself, and I'm just having to do it. So with that, we started a kinship care group so we could provide resources and provide different classes, have special guests come out. And Dr. Washington actually showed up when she heard about it in the community. And because of her wanting to recruit as many as possible that fit the criteria, she was able then to connect with those same kinship care givers that were in the group. Lisa, why do you mention that? I mention that because we all have to work together. And who we are people that are trying to help others that need the necessary help as they are trying to raise these children in kinship care. So again, when we got involved, we continued to recruit, and we started out with our quantitative data, and then we are following up with our qualitative interviews. Right now, we are focusing on and doing our best to make sure that everyone in the community knows what it is that we're doing, so that we can continue to get not just participants, but when we get the data, that we'll be able to give it back, turn it over to the others in the community, people that are working directly with kinship care, families like child welfare, social workers, just everyone throughout the community that can know more. So next slide, please. The lab mission. Again, this is founded by Dr. Tyressa Washington. The African American Families and Kinship Care Lab conducts research and provides services that contribute to the overall well-being of African American and Black families. The lab has a special focus on African American kinship care families. Of course, we understand that with the challenges and obstacles that all the kinship families definitely run into, Dr. Washington's research and the research team, of course, wants everyone to understand and then begin to ask the question, why? She stated in the article that she did, and I'm giving kudos right now to Dr. Washington because, of course, again, she allowed us to be here, but we're representing her in the research that she has done with so many others. One of the things that she stated in the article was we've taken more of a positive approach by asking the question, what are the families doing well? So when you say, what is the mission? What is the mission of the lab? What are the families doing well? How can we find out what it is that they're doing so that we can do what? We can find out what their strengths are and also the resources that they might need, and also then be able to turn around and contribute to the children's social competence, academic competence, and then better behavior health. See, we here can understand that kinship care givers are a unique population, which we're hoping this research will help educate others and provide further resources and support to these families. Another important factor is for us not to forget is that kinship caregivers are not supported financially. They're not supported financially enough. So, and it is a fact that in North Carolina that they don't pay kinship caregivers unless they become a licensed foster parent. So in most of the families, if not all of them that we interviewed, each one of the research team members, we found out that they needed financial help. Not just, okay, fine, they might be getting food stamps. That's great. Somebody else might help them out of the church. That's great too. But when you start talking about different type of medications that might be covered, they're waiting for the Medicaid to kick in. It hasn't happened yet, or something else happened in the home because the home needs repairs. So now they can't take money to be able to buy the clothes they need for the children. I mean, so many different things that require money. And let's not forget the health of the caregiver themselves. The health of the caregiver themselves could be failing, and therefore they're trying to get medicine that they can't afford, give up one thing to get something else. Again, making sure that they need to be okay, but trying to take care of the children too. So when you talk about all of that happening at the same time, we get to a place where why wouldn't a state understand more money needs to be given, and you should not have to just be a licensed foster care parent in order to get the help if you've stepped in? What if you're that church member? What if you're that aunt, that uncle, that older brother or sister, just like the young lady just got finished saying? What if you are that individual? Then what? You need help. You can't finish school. You can't do the things you need to do in order to get what it is that you need. So can we get to a place where on this platform today, we might be able to cut the red tape? Next slide, please. I get pretty passionate about it. Excuse me. So the background on kinship care families. Overall, there has been an increase of kinship care families over the last several decades. 20% of all African-American children will reside in kinship care, as opposed to 13.3% in the general population. African-American children are almost 2 times more likely to live in kinship care with grandparents as Hispanic children, and 3 times more likely as white children. Again, the background of kinship care families. Do we not understand that kinship care has had a long history of informal kinship care and formal kinship care within the African-American communities? Dr. Washington says, and I am quoting her directly, kinship care happens for all races and ethnicities, but it's highest for African-Americans. There is something African-Americans have been doing since the time of slavery. This is something African-Americans have been doing since the time of slavery. I needed to say it twice. During the Great Migration, for example, millions of African Americans left the rural South to escape racial and economic oppression. They sometimes left children in the care of relatives while seeking jobs and establishing themselves in new communities. A common situation might involve a young parent who leaves a child in the care of grandparents to go to college. Other children end up in informal kinship care when parents die. Maybe they're incarcerated. Maybe they suffer from some type of substance abuse or mental health disorder. The point is, when in fact they cannot be present, someone else has to step in. And we are discovering exactly what that looks like every day, more and more. Next slide, please. These factors that contribute to the children's social and academic competence: kinship care family resources, kinship care family functioning, and birth parent involvement. Again, we understand when these families are overwhelmed that if they don't get the resources, it's going to be hard for them to move forward. How can they function as a healthy, productive family? How can the kinship caregivers watch the children that they have laid their lives down for? And I can say it like that because I am a survivor. And I say survivor because I should be dead and I'm not. And why am I not dead? Because there was a kinship caregiver, my mother, who we are celebrating her birthday today, May 25th. If it was not for her, Rosie Sherrod, where would I be? Because of the functioning within the family, because of the resources that she did not have, but made it work anyway. And also, again, because birth parent involvement. There was no birth parent involvement for me, but with research, we have come to find out that it does make a difference sometimes in so many areas, if in fact there's birth parent involvement. Well, that's all that I have to say. And I hope that you got something from what I delivered. It is giving me the greatest pleasure to turn the rest of this now officially in the hands of Joseph Strong. Dr. Strong, take it away.
Thank you very much, Lisa. As you all can see, Lisa is a national treasure, if not international treasure, and we're so happy to have her working with us in the lab. And she's a very tough act to follow, let me say. So I'll speak briefly about the research that we're actually conducting in the lab. We have two studies taking place primarily. First one is an R15, which is an Academic Research Enhancement Award. The title of this research is Families' Impact on the Development of African-American Children in Kinship Care. Our pre-pandemic target sample size was 200 people, or 200 families, we should say. That does include birth parents where applicable. However, numbers have slightly decreased since the world got turned upside down on us. We also have an R15 supplemental study that focuses specifically on the caregivers themselves and looks at the risk factors in the development of Alzheimer's disease. We're looking at such factors as stress and lifestyle health factors as well. We have a control and an experimental group for this trial study. Next slide, please. The goal of the parent study, the main R15, is to better understand the impact of kinship care families on children's social, academic, and behavioral outcomes. Lisa spoke to that previously. Inclusion criteria in this study includes being African American, over the age of 18, and are caring for a child between the ages of 5 and 12. The caregiver, of course, can be blood-related, grandparent, aunt, uncle, etc. May also be of some other relation, such as a godparent, church member, etc. Next slide, please. So these factors, as Lisa spoke to, affect such outcomes in children as social competence and academic competence. Having higher levels of social and academic competence protects families against delinquency, substance abuse, mental health issues, employment problems, and the list goes on. Fewer behavioral problems protects families against placement disruption, which itself is associated with social and academic competence, as well as promotes caregivers' overall health and well-being. Next slide, please. The R15 supplemental study, again, looking at the risk of development of Alzheimer's disease in African-American kinship caregivers, has several goals. So obviously, we're looking at risk factors for the development of Alzheimer's disease, such as stress, factors related to stress management, cardiovascular disease, and other health disorders. We're also looking at positive lifestyle factors that African-American kinship caregivers rely on to reduce stress and promote physical health. And we're also looking at negative coping strategies that might amplify poor physical and mental health outcomes. Inclusion criteria for the experimental group includes enrollment in the parent study, the main R15. Inclusion criteria for the control group involves just being an African-American non-kinship caregiver over the age of 18. Next slide, please. Kinship caregivers face unique challenges, such as parenting for uncertain periods of time, and often with scarce financial resources, as we've heard before. This places them at significant risk for high stress levels. Recent findings indicate that there is a link between chronic stress and Alzheimer's disease, so there's a strong need for research to identify possible stressors and mitigate risks among kinship caregivers. Next slide, please. So obviously one of our main goals of the lab is to improve outcomes overall for children in kinship care, as well as outcomes overall for kinship caregivers themselves. So we do this by identifying what has been known before through research and theory. We also look at culturally relevant interventions, as well as the development and proliferation of culturally relevant interventions to improve outcomes overall. Excuse me just a second. Here we are. So African-American kinship care is an understudied area. Given the unique challenges faced by and strengths within the African-American kinship care community, a collection of this type is absolutely crucial. Our work contributes to a growing body of knowledge within this domain and serves as only the beginning of a research trajectory that's intended to reach far and wide. Next slide, please. If you have any questions or know of anyone who may qualify for one of our ongoing studies, this is our contact information here. And I thank you very much for your time and attention.
Thank you so much. We are excited to hear more about what comes out of this in the future. So thank you for setting that up for us and for your passion. We're now going to move to our next set of presenters from the Family Focused Treatment Association. And I'm going to introduce Erica, and she'll introduce a couple other folks that you'll hear from a bit later. Erica started her career in Pittsburgh, Pennsylvania, working in residential treatment. In 2001, she moved to North Carolina, at which time she started her career with Methodist Home for Children. During her almost 20-year career with Methodist Home for Children, she managed group care and foster care programs. In 2020, she started her own company, and she works with the Family Focused Treatment Association and oversees their North Carolina Kinship Therapeutic Foster Care pilot, in which she supports public and private partners as they join to promote interventions in kinship homes. She has a passion for improving the lives of children and families served in the child welfare system. Working in the foster care system for the past 19 years has taught Erica a great deal about the need for system change, the power of family, the importance of community, and the need for strong leaders. So with that, I'm going to turn it over to you, Erica.
Thank you, Jennifer. Just making sure you can hear me okay, so let me know if you cannot.
We can hear you great. Thank you.
Perfect. And I do have two partners with me today, and I'm going to introduce them as we get closer to their presentation. So let me just start with talking a little bit about who Family Focused Treatment Association is. You'll hear me reference this group as FFTA, and this is a group that I currently work with in North Carolina. So next slide. So I wanted, sorry, I'm so sorry. Before we get started with FFTA, I want to ground us in, it was great to hear from both of our presenters earlier. And I wanted to ground us and hear from another provider. So we're going to listen to a story from Miss Rhonda, who has participated in the national campaign this year. So she is located on the website, and you can find her story along with others. And so if we could play that first to kind of ground us on who we're talking about for the families that are in our pilot.
My name is Rhonda, and I've been taking care of children in my family for the past 40 years. Over the years, I've cared for my siblings, nieces, nephews, and 2 sets of my grandchildren. Taking care of family, children, and people in need has always been something that I've done. Some would say that I'm just a natural caregiver. I'm currently a licensed therapeutic foster parent in North Carolina, caring for my 2 teenage grandsons. I work in partnership with my local Department of Social Services and a private agency. This is the first time in all of my years caring for relatives that I've become a licensed foster parent. Prior to this, all of my other relatives were not placed in the legal custody of the state. So I was able to step in and support them without having the involvement of social services, which at the time made things easier. Back then, I was able to make all of the decisions for my relatives, but I had to build my own support systems in the school and community. I also had no financial support or training. This time around, I don't get to make all the decisions, but I do receive support from both social services, the private agency, and I receive financial support. Even though I was hesitant to become a licensed foster parent, I'm glad that I did. I learned so much from the training, most importantly about trauma. I also receive a lot of support. Through everything, my private agency has been in my corner. My advice to others: let your guard down and let others come in and support you.
Oh, thank you so much for showing that. Again, that's Miss Rhonda, and she is one of the kinship caregivers that's involved in our pilot, which I'm going to be talking about today. So let me back up and tell you a little bit about FFTA. So if we can go on to the next slide. Like I said, Family Focused Treatment Association, also known as FFTA, works to advance best practices and advocate for policies that support families in their care and for in treatment for children. So this is a membership organization. It's been around since the 1980s, with a focus initially. Can you guys hear me?
Yes, you muted for a second, but now you're good.
It muted itself. I'm so sorry. All of a sudden, it just popped up and told me I was muted. Okay, so FFTA has been around since the 1980s with a focus on treatment foster care and advancing the field's understanding of effective methods. Today, we're focused more on treatment family care and really involving kinship caregivers in the services and their stories and the work that we're doing. We have about 500 members in our organization, and we lift up the voices in the needs of those children and families that our members serve. Next slide. Our membership encompasses both public and private, and that's who is part of our project and will be speaking with us today. We have both large and small organizations from 47 states in the United States and every province in Canada. We operate 24 chapters, so there's 24 state local chapters that have an operating body that help us to move this work forward and support the partners that are in those states. Our members do a wide range of service, as you can see from this list, from treatment family foster care services to family preservation, in-home services. So there's an array of service providers that are in our network. That's a little bit about who FFTA is. I want to talk to you a little bit about our philosophy about kinship care. So next slide. So FFTA has a strong belief that when appropriate, young people should be staying with their family. And so that is fictive kin or kin blood relatives, and that treatment could occur in that setting. So that's how we arrived at the project that we are doing right now, is looking at the intersection between treatment and kinship care, and how young people can receive services in family settings rather than being in higher levels of care. So that's a little bit about where we started our approach. Next slide. So back in about 2013, 2014, FFTA started to work with their chapters in promoting kinship summits to carry on that kinship philosophy and see how we could impact our providers and really move the needle more towards a kin-friendly approach. And so those kinship summits started in about 10 states. So all those 10 states all had chapters, and they convened with public and private partners, mental health providers, different stakeholders, family members, alumni, and in North Carolina, that's where we started. So North Carolina started with kicking off a summit in 2015, and we had a great summit. And following that summit, we had our chapter come back together and say, there's more that we could probably do here. And so our chapter in North Carolina, a very strong chapter, big chapter, is largely comprised of private providers. And these private providers came together and said, we support kinship work. We want to see how we can get more involved. And that's what really kicked off the partnership between the North Carolina chapter and FFTA National. The 10 different partners that came together were just really interested in seeing how they could be involved earlier. They were seeing kinship caregivers after guardianship or after adoption, and they were coming to the private providers looking for service for out-of-home placement. And so that, for a lot of the private providers, we wanted to get involved earlier to help these families to maintain their permanency and not have to look for out-of-home placement, which sometimes was resulting in them giving up their guardianship or overturning their adoption. And so the providers in North Carolina thought, well, there's more that we can do here. And what if we help support this idea of treatment foster care inside of kinship homes? So that's where we moved forward with our project. And we started looking at higher level youth that were in PRTFs or group care, and saying, why couldn't we put them in with homes with relatives and give them the same intervention of treatment foster care and help them move towards stabilization and permanency? So that's really where we started our work. And in North Carolina, we could only do that work through a public-private partnership. So the referrals come from the public entity, but in North Carolina, it is the private partners that train, license, and supervise treatment or therapeutic foster care. Next slide. So we were very fortunate to get funded with this vision that we had from the Duke Endowment. And we have been funded for the past 2 years. This is our final year. So we started in 2020, and we were fortunate to have a planning year for our initial year and then 2 intervention years. So we will wrap up our second intervention year this December. I wanted to note, since that different states do this differently, I wanted to note that we do have funding from the Duke Endowment, and since we are looking at licensed facilities, there is assistance from with room and board from the public entity, but we also are able to bill North Carolina Medicaid for kinship TFC underneath our TFC definition. So we have a couple of different streams of revenue that are helping to support this work that we're doing. Next slide. So the design of our project, and like I said, we started with a year of planning, which was amazing. You don't really get that very often. And so we were very fortunate in that first year that we came together with an advisory group of stakeholders, which also consisted of alumni that have been in kinship caregiving situations and kinship caregivers. And so we were able to develop that advisory group and really take that first year to think through what would work, what doesn't work, and what needed to happen to remove barriers to help move this needle forward. So we were able to have lots of great partners alongside of us every month coming together and really thinking about the various buckets of work. That led to application for the pilot. And again, our advisory group helped us with that. And we were able to select 3 public and 3 private partners. So there's 6 individual agencies altogether, but there's 3 pairs that work together on moving the project forward. We worked in partnership in our first year with Child Trends, and they're still our evaluation partner at this point. And we developed our logic model in partnership with our advisory group, with our members and Child Trends, and really trying to look at what Child Trends and our group really wanted to focus on is how effective we could be with kinship treatment foster care. So what are what's working, what's not working? What does training look like for kinship caregivers? What does training look like for staff? Are families getting the support that they need? Are public and private partners able to work together to actually pull this off and provide a service? And so those are kind of where we started in the beginning of our work with, looking at some research questions around those topics that I just mentioned. Next slide. So our approach really is 3 main things, and that's partnerships, learning community, and coaching. So we started this work very rooted in partnerships. And like I said, we started with our advisory group, which was public-private partners and various stakeholders coming together to share and learn and help develop the project. We knew that we could not do this without these partnerships. And like I said, in North Carolina, public agencies are the referral agency, private agencies are the agencies in this project that are carrying out the treatment foster care. So our partners came together soon after they were accepted into the program, and we brought them into various work groups and trainings to really level set and make sure that everybody was speaking from the same sheet of music. Public and private partners really do come in and look at kinship care different from different lenses because they have different experiences with relatives and in this work. And so we learned that very early on. So we were very fortunate that before we even started implementation, we got to bring our public and private partners together around training. And we were fortunate to have UNC and Child Focus as great partners to help us to do that. And we started with some just fundamental training on what kinship care is, what kinship care isn't, looking at the factors that affect families from their point of view, like substance misuse and mental health. And so we were able to have a 4-part series that really launched us into the project. So that really helped us to build the foundation for our partnership and opening the lines of communication, building trust with one another, having shared responsibility. It really started before we started the intervention. Once we started the intervention, by intervention, I mean started to train and license kinship caregivers, and we trained families in a model specific to them, specific to kinship caregivers providing treatment or therapeutic foster care. So before we started that intervention, we kicked it off and families were getting trained. We started a learning community for our public and private partners. And that learning community was for all of last year and all of this year. We've done it different in both years to really meet the needs of our public and private partners. But those learning communities were a chance for people to come together and talk about various topics that were barriers to moving the work forward. So we spent a good part of our first year talking about search and engagement. And the reason we started there is because more than 50% of the young people that we had identified for this population, more than 50% of them still needed search and engagement. They did not have any relatives or fictive kin caregivers that could help support them through their journey. And so we said, okay, we really need to bring and shed a light here on this. And so we brought in one of our another partner to our group to really share about the experience of search and engagement and the emphasis on engagement. And we did that in the beginning of our learning community, which really helped set the tone for that year. This year we've picked up and we've really talked to our partners on other topics that they find important to address for moving this work forward. Some of the topics are licensing issues that we'll be talking about soon next month. We have brought other partners to come and talk with us about sustainability and how do you move from initial implementation to ongoing implementation. So there's been various topics that we've been able to move through to really help support our partners in their relationship. Coaching is the last thing that was part of our approach and continues to be part of our approach. So all of our peers have a coach assigned to them, both last year and this year. So in conjunction to their learning community, they have coaches that come in and guide them through the process and help them to problem solve and brainstorm. There is even times that they're doing case consultation to help move things forward and eliminate those barriers that might be holding people back from either placing or providing appropriate service to kinship caregivers. So those are the three aspects of our project that have helped us to move along and get to a point where all three of our private agencies are able to implement KTFC in their area. Next slide. So I just want to quickly go over some of our findings, and then I'll introduce our two speakers that you're wanting to hear from that actually do the work. So what Child Trends found out in our initial findings are agencies really did recognize the value of KTFC, which was huge because at first, some people could be a little bit skeptical about doing this intervention, but they recognized the value and they realized that collaboration was really key. We did notice with the training for both staff and kinship caregivers that knowledge and attitudes changed after their initial training. So both groups went through initial training. Both of them had pre and post tests, and we did see an increase. We also noticed that kinship caregivers' well-being was enhanced through the relationship and the support that they received. And this is huge because, a lot of our caregivers were kind of feeling out, left out and on an island. And coming into this project, they really felt wrapped around from both the public and private agencies. And they were able to see that they had different roles, but they were able to see that they together were working in partnership with the kinship caregiver. And that really did make our caregivers feel well supported. Next slide. The initial implementation was very time consuming. I think all of our partners thought that, and it is hard taking something that we had not done really before and kind of coming together and lifting that up. And so there were a lot of, things that needed to happen to look at process and procedures, to talk through communication, to talk about, everybody's roles and what people needed to do and really get on the same page. With their values and address any bias that might be there. So it was a little bit time consuming in the beginning, but it was well worth it. And the one thing I want to point out that whenever we looked at our numbers, the majority of our caregivers already had young people in their homes. So initially we thought we were going to focus on young people on higher levels of care that needed search and engagement and help to bring them into kinship caregiving situations. But what happened was it was very difficult to get the search and engagement the way that we needed it to be because some of these young people had been in placement the majority of their lives. So what ended up happening is we started to look at different caregivers and caregivers that were already providing the service. So like I said, most of those families, we use this as a preventative measure. So they were providing service. They were not licensed at that time as therapeutic foster parents. So they got the training and licensure and helped them to sustain their placement. The last big thing that we noticed in our first year is that the technical assistance, the coaching, and the training were a very valuable part of this project. And we found that they were instrumental with moving the project forward. Okay, so That was my time is up. If you heard my buzzer go off, I apologize. But those were just a couple of things that I wanted to share with you guys. I do want to move forward and introducing you to two of my partners that have been involved in this pilot from the beginning. And that's Kimberly Harrington and Shalita Lee. So I want to just tell you about a little bit about each of them, and then they're going to talk to you about their experience in the project. So Kimberly Harrington is a permanency manager with Wake County Health and Human Services. She is a native of Chicago and began her career as a social worker with the Illinois Department of Child and Family Services. She transitioned to Raleigh, North Carolina over 25 years ago, and she has dedicated her career to child welfare services for over 30 years. Currently, Kim is a manager for the foster parent recruitment and licensing, adoption and post-adoption services, kinship licensure, guardianship assistance program, and foster care Medicaid eligibility. In other positions, Kimberly has served as a permanency service social worker, a linked social worker, and an adolescent foster care supervisor. Kimberly has dedicated her career to serving children and building the capacity of families, adding in timely permanency and improved well-being for children. She has also been a strong advocate for parents and building strong communities. When she's not making magic happen, she enjoys spending time at the beach, reading a book, or gardening. Kim earned her Bachelor of Arts degree in psychology from Western Illinois University and a Master's of Arts degree in psychology from Chicago State University. Shalita Lee is our second presenter today, and Shalita is currently the Director of Foster Care and Adoption with Methodist Home for Children in Raleigh, North Carolina, where she has been employed since 2010. She was recently presented the Employee Excellence Award for her exemplary work and continuous service at the agency. Shalita serves as the Secretary for the North Carolina chapter for FFTA. She received her MS degree in Child Development and Family Relations from ECU in 2010 and her MSW from North Carolina Central. Shalita is a licensed clinical social worker with several years of experience working with children and adults with mental health, intellectual developmental disorder, and substance misuse. She is always passionate and eager to cultivate the lives of youth and families while seeking to maintain a standard of excellence in all that she puts in her hands. So I just want to move this over now to Kimberly and say welcome, and I'm going to mute myself and turn it to you.
Thank you, Erica. Next slide, please. Good afternoon. As referenced, I'm Kimberly Harrington with Wake County Health and Human Services, and I've had the gracious privilege of partnering with our private partner, Methodist Home for Children, in this endeavor. Here at Wake, we've been extremely fortunate to have the support of our executive leadership, which is very important, from the onset of our partnership, and have been afforded the ability to present new options for kinship engagement, support, training, and maintaining and improving family connections, placement stability, overall well-being, and permanency for children in our care. The initial planning phases were time-consuming, and there were growing pains that needed to be addressed. However, we remained persistent, and we worked through those phases of development. When working with partners, it is key to ensure that you have a clear outline of goals, and specifically, we found that when you address the shared goals among partners, it brings you to the table easier and supports the professional connection. We began our journey with our project team, and we met consistently to discuss and establish core goals and to gauge what would make this project successful, developing our scope of work, comprehensive planning sessions, having candid communications in safe space, and being able and willing to tackle the difficult matters as they came up. When we look at what would make this very important, partnering to support permanency, connections, and stability for children, those components are looking at ways to identify kinship sooner. We all know that children thrive when with family. That is our goal. We also have to look at multiple ways of supporting the licensure process, not limiting ourselves to the one course of action. We're all accustomed to doing business a certain way. We have to move. Supporting kinship caregivers through their process. As we all know, licensure may sometimes be a daunting task, and we have to be willing to walk the journey and encourage families through. Ongoing engagement and assessment of individual family needs, because each process is going to be different. Every family is unique. Strong partnership and shared values. Working in tandem brings about success. We have to be willing to partner with each other in order to move. Next slide, please. Partnering to support this action has been so important. And as we do that, we have to look at what our identified roles are. While we may have started out as public versus private, and that remains our entity, we became one blended agency working with defined roles, establishing subgroups that would specifically address licensing, information sessions for families and staff, screening tools, training, search and engagement, and even looking at our data and technology needs. Working in tandem enhanced our engagement and service delivery and was found to reduce duplication of effort and move the team forward. Establishing processes and procedures. Evaluating and ensuring you have a solid process in place for how to move forward is critical. Each entity must be clear on what steps are on each end. Thus, we developed a systematic process, yet flexible approach based on each unique family dynamic. Increasing the communication is important because, of course, without communication, many partnerships may falter. It is critical to stay connected, to openly share successes, challenges, and needs. It is necessary to convey what the challenges are of the respective agencies and how each other can potentially offset or support that potential gap in service. You are able to identify then and broaden your scope of service, increase training opportunities, build on respective strengths, and work through the logistics with greater ease, mutual respect, and understanding. When you look at increased accountability and shared responsibility toward a common goal, those two go hand in hand. We have to fully understand what is expected. It is holding individuals accountable and the collective leadership group. Building a platform that allows everyone to take ownership of the process and establishing short and long-term goals is vital to getting everyone in the group on the same page. It allows for consistency of practice and working collectively to break down barriers to achieving the goal. Our success is ultimately defined by the family's success. Knowing that things change, as a project team, remember you should always be willing and able to adjust and reinforce the goals as needed. Process mapping for both partners. For each agency, it was necessary for us to determine what our current internal processes were from prevention through the achievement of the permanent plan, and to identify pain points that required additional attention, support, or complete changes in our process that would support the FFTA work. Kinship processes for public agencies versus private agencies are different yet similar. When completing our mapping process, we were easily able to identify common goals, and it helped guide the defining of roles and responsibilities for the individual leaders. Embedding the process into the work. Ensure that kinship becomes an integral part of the work within your agency and collectively as private and public partners. It has to be encouraged from your leadership through your frontline staff. It is vital for the success and support of the families that all staff, middle management, and leadership see and understand the value of kinship and how ensuring kinship engagement better supports the well-being of our children. While there are often challenges in child welfare with turnover, you must ensure that there's a solid transfer of learning process in place. Next slide. Now, Certainly, we've had numerous successes, and yes, there were some challenges faced. And what you will see here is that, a lot of it started from having buy-in from the agency. And so in order for us to do that, we needed to increase our efforts in allowing more persons to be included by broadening our circle. And that needed to happen from all layers of the division. We worked on this with increasing information and more inclusion, having meetings with supervisors and workers to staff cases initially and ongoing. The assessment phase was also important. We had to adjust our traditional process. As I referenced earlier, we have to be willing to move. We have to understand that there's going to be necessary pieces to the puzzle that are unique to kinship providers. Partnered with our private partner in order to have information meetings that were unique to the population as well, and utilizing our kinship screening questions to get to the core of really what tools are needed to make this successful for the individual family. Reducing bias, ensuring that our service provisions were equitable, meeting families where they are, and being flexible. As a public agency, we found that partnering with Methodist Home for Children to engage families directly allowed for an external connection to support the process, reducing public agency stigma attached to licensing. Silos. You have to break down the silos within divisions, functions, and areas of service to support the effort. Understanding that engaging and supporting kinship at the onset of the agency's involvement with any family is important. Helping other functions understand how they tie in will help yield improved results. When hiring new staff, onboarding should be intentional. We want people to come a part of the agency with lived experience who can move this work forward, and training and sharing of the agency's core values around kinship care and support must happen initially and ongoing throughout all levels. And certainly, we have functioned and we continue to function in this agency, this state, and in many states across the country with limited resources. Turnover in child welfare will always be a challenge. And understandably, there has been an unprecedented number of vacancies in the last few years that have been, and several programs that have been forced to limit access to their resources for our families. This is definitely, again, yet another reason and certainly an opportunity for public and private partnership to leverage the resources and staffing you have to partner for much needed services to our community. Even with limited resources, we have the capacity to build our resource teams and work collectively toward a common goal. Thank you so much for your time. Shalita.
All right, good afternoon, everybody, and thank you, Kim. Thank you guys so much for the opportunity to participate in today's event. And Erica hit on this, and so did Kimberly, but one of our leading principles as a private agency partnering with a public agency was that, we know that outcomes are better for the whole family when children are placed with their relatives. And not just, relatives who don't have those services of support, but they're more successful when the relative is actually trained and supported to really consistently be able to meet the needs of the children that are placed in their home. And so through our partnership and through the KTFC intervention, we really focused on enhancing the skill set of social workers. And that was just on the private as well as the public side, so that we could effectively work with kinship caregivers, as there are very unique differences in how we support a traditional foster parent versus a caregiver who is providing that care and support to someone that they are either blood related to or have that kin-like relationship with. Another thing we focused on was being able to improve the safety, permanency, and well-being outcomes for children and adolescents through the KTFC service. And then lastly, by enhancing the consultation and training provided to caregivers who are parenting children who have experienced trauma and or are having difficulties in the home, school, and community settings. Next slide. We really believe that we were able to accomplish this and are continuing to move the work forward by focusing on 3 different areas. And the first one is in the area of training and education. And so this is an area that our KTFC caregivers reported to be extremely helpful. The training that we provide to them provides a very in-depth review of trauma. It teaches them how to engage with children who are struggling with managing their behaviors. It provides some information about mental health challenges and mental health diagnoses that children sometimes experience while they're have that child welfare involvement. It even provides insight around substance misuse, and even helping them be able to navigate the crisis management and how to respond when children do go into crisis situation. With regard to permanency, we had children, as Erica mentioned, who needed that search and engagement. And so with the pilot, we've been able to identify potential caregivers who may be available to support the children and to help in the process of transitioning the children from the higher level care into the relative caregiver's home, while also, providing them that training, that education, and overall support. We focus on assisting families with knowing their options and the financial resources that are available. As was mentioned earlier, a lot of time kinship caregivers don't have that financial support, and sometimes that's their greatest need. And so through this pilot, we've been able to connect them and make sure that they're aware of what resources are available to support them. With regard to support, I'd like to just share a little bit about what the support looks like on our end within this partnership. Is that, Methodist Home for Children is a private agency, and providing that therapeutic foster care, we provide the 24/7 crisis support to all of our licensed homes. And so if that means that a young person who's in a kinship home goes into crisis at 9 p.m. at night, the kinship caregiver has somebody to call who will walk them along the journey of helping that child de-escalate, helping that caregiver know if additional support and services is needed. They may look like, someone from my team going out to the home and helping that caregiver. That may look like, someone from my team meeting that caregiver at the hospital in effort to make sure that that child's needs are immediately addressed if they're being unsafe. We also offer through this pilot kinship support groups, so that there's such great value in having that connection with other people who may be experiencing similar things as you. So we provide them that opportunity to be able to engage in those types of relationships. Routine consultation, and so our staff are doing supervision on a weekly basis, ideally face-to-face inside of the foster home, so that they're able to talk about the specific behaviors. We're able to talk about the different interventions. We're able to talk about progress in the school setting, progress with therapy, and just brainstorming and even checking in with that caregiver about their self-care routines to make sure that they also are caring for themselves. Not only are we providing the consultation to the family weekly, but our staff are also receiving that weekly supervision from their supervisor, just to make sure that there's no blind spots that are going unaddressed in our overall partnership. We do routine assessments to make sure that we are able to provide the right treatment services to young people who come through our program. And some of those assessments include the child behavioral checklist, the youth outcome questionnaire form, which again helps us to make sure that we are appropriately addressing any of those needs that a child comes to us with. Next slide. So this approach has really been helpful for the families that have moved through our program. And so within the KTS intervention, just thinking about what's working, we've gotten a lot of feedback from caregivers about the training and support, as Erica mentioned, I think earlier, about sometimes feeling, caregivers feeling as if they're on an island by themselves. And so with coming into this particular pilot, they've been able to get that additional support. They've been able to get that additional training and education around the behavioral concerns, or around the mental health needs, or around the trauma that the children who are placed in their home have experienced, so that ultimately they're able to respond to them in a more trauma-informed way. Supports and permanency. And so with this intervention, in some cases, when the family has been introduced to the licensure process, sometimes the children are just having behaviors every single day. And so we've been able to step in with this program to be able to help stabilize the placement, so that the child doesn't need to go to a higher level of care. And so that is another thing that is really working for us and for this program, and allowing us to be able to help that child ultimately meet their permanency plan goals. And so those are some of the things that are working. With that, there are some things that have been identified for areas of needed improvement. And mainly that has been for us, working with other mental health providers. And so in the state of North Carolina, we have in-home services that are providing, sometimes we call it intensive in-home. And so in those situations, they're going in, working inside of the home with the caregivers as well. But it's been a barrier in some cases to get the other mental health providers that are engaging to quickly, come to the table to reassess the child's need, to make those clinical recommendations, to update that child's treatment plan so that we can start that KTFC intervention. And so that has been one of the barriers that we have experienced and we're continuously working on. The supporting authorization. And so also with the getting updates on the clinical assessment or the psychological assessment or diagnostic assessment, updating the treatment plan. We've had the managed care organization, which are the people who oversee the Medicaid funded services in North Carolina, at the table. But with that, sometimes that information may not make it all the way down to the line staff or utilization reviewers. And, they may or may not be willing to have a full or comprehensive understanding of the KTFC. And so they're more likely to deny the KTFC program than actually, fully understand and say, yes, this is a service that will benefit this child and prevent them from going to a higher level of care. And so that is an area of improvement that we are constantly navigating and working through. The last challenge that we identified as needing improvement is really emphasizing treatment versus timelines. And so as many of you guys are aware, there are set timelines that I think our public providers are required to meet. And so just being able to find that balance to make sure that we are focusing on the treatment needs of children, because if we do our due diligence to provide the children with the treatment that they need, ultimately, we would be able to maintain and reach that permanency plan goal and would not see kids then being re-entered into the system. And so that is another barrier that we are continuing to work on a daily basis within our partnership and within the delivery of this particular intervention. So thank you so much, and I'll pass the microphone over to Erica.
Thank you, Shalita and Kim. That was great. Very informative information. I just wanted to wrap us up before we get into some Q&A, just to again remind us that this is a partnership. That's what these ladies have so eloquently stated. It's a partnership between public and private, but again, it's a partnership with your kinship caregivers, and really making sure that your kinship caregivers are a part of this process at the table, and that they have a real voice. This partnership has worked so well in including families that Kim and Shalita just recently celebrated one of their first cases that came into the pilot several months ago. I think the family received about 8 months of intervention, and just last week, the week before, they celebrated an adoption with an aunt and an uncle for a young person that was in the service. And to get there, it really took a strong partnership between not only Shalita and Kim and their group, but that partnership with that family, and hearing that family and listening to them whenever they say, we need assistance, we need an intervention, we want to get to permanency, but we need some support to get there. And with their partnership, they were able to celebrate an adoption 2 weeks ago. So just want to commend Wake County and Methodist Home for Children for all the great work that they're doing. So thank you guys. And I'll pass it over, I think, to Jennifer again.
Yes, thank you, Erica. And thank you, Shalita and Kimberly and Joe and Lisa and Antisha and Lanita. Thank you so much for all of this. This was amazingly informative and helpful, and appreciate everybody's passion. We have a few moments to do some Q&A. So if you guys have some questions, please feel free to continue to post in the chat. Erica, the majority of the questions that have come in so far are for you and your team. So the first one is, Kinship Treatment Foster Care available for other states as a pilot program too?
So it really depends on the jurisdiction and what they have going on in their area. FFTA right now is supporting this partnership in North Carolina and looking at other states that are in our partnership. But like I tell everybody, anybody can take the information that we have, and if their state is willing to move forward, could adopt this program and get a funder just like we did at FFTA. But we are working right now with our membership to try to see if there's any opportunity to move this to other states as well.
Great, thank you. And we had another question. What is the name of the specific training used?
So in partnership with UNC, we developed a 10-hour curriculum. So in North Carolina, you need to have 30 hours for pre-service, and we didn't touch pre-service. Our agencies use different things like TIPS MAP or Deciding Together or Caring for Our Own. What we focused on was the 10 additional hours that you need to be a therapeutic foster parent. So FFTA, in partnership with UNC, created a training that met the standards for North Carolina, and those were the various areas that Shalita mentioned.
Great, thank you. The next question is, was it difficult to convince Kin to get licensed and trained?
So I can answer that, but I'll see if Shalita or Kim wants to take that, since they had the firsthand knowledge. Did you guys think it was difficult?
I don't think it's difficult to get families licensed and trained. I think the difficulty, or most of the difficulty that we had at the onset, is getting families to the door. And so being able to kind of break down those initial barriers to ongoing intervention from the child welfare agency, helping families understand that this is a resource. And that was one of the reasons why we developed a kinship specific information meeting to really tailor our conversation and answer questions specifically that kinship providers that would be unique from a traditional parent being licensed for foster care or therapeutic care services. Shalita can speak to the actual training pieces.
So I agree with what Kim has shared. I think it was just a matter of helping the families understand the benefits of coming through and getting licensed and getting the additional training, and how our agency could partner with them. So yes, it would be another person coming into your home, but we are a support person for you to help you make sense of absolutely all of the different systems that we have within our state, navigating the mental health system, navigating the educational system, navigating the child welfare system. So it's like we're just like a buffer. So I think it was, once we got the families to train, and they were very open. But I do think that, initially it was kind of like, okay, this is something else that I have to do. And so I think we did a good job. We learned a lot in the process. And so I think over the years, we have been able to, come alongside each other and approach the work together, which has been extremely helpful in how we are addressing and initiating those conversations and contacts with families.
Thank you. We have lots of questions coming in. For kinship caregivers who are currently providing support to youth, will they be able to be a part of the kinship caregiver program?
I think that was from Christy. Hey, Christy. She's from North Carolina, I believe. That's somebody that we know. So we are in 3 counties in North Carolina for this pilot, and that's New Hanover, Wake, and Cabarrus. And so those counties make the decision about how families move over to the service. And so if they're eligible, if they have a young person that's eligible for therapeutic foster care, then they're eligible to be a part of this pilot. If somebody is in a different county, it's not that you can't do this. And so I would just, if you're in North Carolina and you're trying to figure out how to do this, you can certainly contact me, and we'll put my contact information back up. Anybody could do this. We're just doing it with support, if that makes sense. So if somebody is not in one of the pilot counties, they can still do this approach. They can still work in partnership with an agency that has shared kin values, and still move forward with a therapeutic foster care authorization.
Fantastic. How would you best approach onboarding for kinship and bio families that are not receptive to the protocol necessary to qualify as a kinship placement potential? Example, background checks and drug screenings, etc.
So I can speak to this quickly, and then if Shalita has more to add, but I would say that what we learned very early on was messaging is key. And I think everybody knows that, like, oh yeah, that makes sense, but really paying attention to messaging. Our division did a great job a couple of years ago, putting together a know your options guide that really talks about what the different options of licensing are and permanency are. And we shared that with our pilot partners. We also developed a resource guide specific to kinship caregivers interested in this project. And that also helped with messaging to help families to understand what this project is, what it isn't, what are the various things that you have to complete for licensure. And so I think those two things helped. And then in addition, helping the frontline staff with their messaging, I think all of that was really key. Shalita, would you add anything to that?
No, I think you covered everything perfectly.
Great. We just have a few moments left. I'm just going to mention that we're going to post a link to the evaluation of the event in the chat. So we would appreciate if you all could take a moment to provide us your feedback. There were a ton of questions still left. So Erica and Kimberly and Shalita, if you don't mind, I think we'll send them to you all. And then when we send the recording and the PowerPoint out to you all, we'll send the answers to those questions as well, so we can make sure that you guys get the answers to all the questions that you have. So with that, we just wanted to say thank you for all of your time and attention and participation in today's event. Thank you very, very much to all of our wonderful presenters. And again, everybody, we will make sure to send out the PowerPoint and the recording to folks who attended, and we'll get those answers to you as well. And with that, I hope everybody has a great rest of National Foster Care Month, and we'll see you next year. Thank you.
Thank you, everyone. We will now end the call.